didn't really wanna bore you with a full couple hours lecture on it. Cause I just don't really think there's a great way to make it fun, so. But if you look on that module page, cause I know y'all were focused on your test yesterday, you'll see that there's the recorded lecture that I was talking about earlier that you can listen to. It's following this PowerPoint. I think the theme may be different, but it's the same stuff. And then just don't judge my monotone, okay? It's hard to sit in your office and lecture to a computer screen. And then there's also the PowerPoint that you can download, and it has extensive notes under each slide. That's what I would personally recommend, just because then you don't have to worry about like interpreting anything that I'm saying or trying to spell it correctly or anything. And then there's also an activity that's through like a Google worksheet thing that y'all can do once you look at all of this content. And there's like quizzes, like a few little content things, and then some quiz questions that you can work through, and it'll give you rationales for all of the answers and everything like that. And it's like an interactive worksheet that I created that you can do. And students used that last summer and they really liked it because they could actually go back and redo it multiple times as they looked at the content more. And then there's also links to several websites and I think a video or two or something like that over on the additional resources that can be really helpful too. But also you could do the same thing, like put any of this into that Google Notebook and it'll make that podcast if you want it to. I did it specifically for this to see what it would do, and it does a good one. And it's like, I think it does it in like 18 minutes or something, and it kind of hits the high points of them. And it's two people talking back and forth. You can change their accent too. So if you want to add a little bit of spice and listen to a different accent, you can do that. But so the big things that you're going to want to focus on here when we're talking about like the cataracts, glaucoma, trauma, your nearsightedness, farsightedness, is walk through your normal like nursing process and like how we look at things. So when we're looking at all of these different causes of eye alterations, hearing alterations and things like that, we know that all of them can cause similar symptoms. When we're looking at aging, we're looking at more of our age-related vision changes. So that may do like some nearsightedness or farsightedness. It may just be needing to wear some reading glasses because you have trouble focusing. Age-related changes also can be like your cataracts and things of that nature, right? But when you then look like at myopia or astigmatism or whatever it may be, walk through what caused it, what are the risk factors that got you there, and this is all in the notes sections, right? And then your clinical presentation, so what's the patient gonna look like, what are they gonna complain about, what are they gonna describe, and then how are we gonna treat it. If you can talk about at least like the most important one in each of those sections, you should be totally fine in this sensory stuff, okay? This is not rocket science. It is not super complicated. There's a lot of really fancy words that I even really struggle with because I'm like, I've literally never called it myopia. I've only ever called it nearsightedness, things of that nature. So I also get tongue-tied a lot in my recording. But if you can kind of hit the high points for each of those, like cataracts, glaucoma, all those exemplars that are listed, it's really the depth of what you need to know here, okay? And then also, inside that with your management and treatment, management also entails what are we doing nursing wise, right? Well, if I have someone that has a really difficult time seeing, I'm probably gonna adjust some things for them, right? If I have someone that's either legally blind or totally blind, or maybe they have severe cataracts where they really can't see anything, then maybe I'm gonna talk them through where I have things set on their tray. Or maybe, I'm sure y'all have seen like a call light, sometimes we'll put an electrode on the button that calls the nurse so they can feel the electrode to know exactly what button they're pressing. Yes, those buttons have Braille, but most of the patients that are dealing with just like common eye issues or sight issues don't know Braille, right? It's not widely known language. So it doesn't feel any different to them than the button that raises the head of the bed, right? Or that changes the volume on the TV. So little things like that. If you're setting up their lunch tray, use the clock method, right? Y'all familiar with that? You say, hey, I've got your juice at 2 o'clock, your forks at 6, whatever it may be. Think more about all your safety. So if you have a patient that does have some issues with their sight, how am I gonna navigate them around the room? What things am I gonna talk to them about removing at their home? What do we know are the things that we're gonna talk about? Rugs, cords, thresholds, right? Wearing shoes, things of that nature, because even though maybe they have plenty of balance, if they're at higher risk of not seeing something that they could trip over, shoes could potentially have a little bit more traction than just being barefoot, right? They also might not see something that could injure their foot and step on it. So shoes would be beneficial there. So think safety, because safety is, and that's not necessarily saying specifically to me for testing purposes, but safety is such a huge, huge thing that HESI likes to do for things like this. Because that's what's gonna really make the difference between how they're being treated right now and then how we could help increase their ability to do things and maintain their autonomy, right? Understand that, what do we know that cataracts are? Because a lot of this stuff y'all have heard, right? Or seen, or maybe experienced. So does anyone know what cataracts actually are?
The lens.
Yes, the lens, which I will say too, what would really help is if you reviewed your eye anatomy. I don't know why, but eye anatomy always confused me when I was like learning anatomy. I would get things confused and I'd be like, I don't know what that is. I think just because everything's right there on top of each other, but review your eye anatomy, and that makes it a little bit easier to understand. Y'all did the sensory lab over in the sim lab last semester, did you? No, maybe?
We did.
Yes.
They feed you and blind you.
Yeah, we didn't feed each other in the days, but sure, yeah. We did some other things, but yeah. But you wore like the goggles and things like that that kind of made you have some differences in your vision, right?
We did it here. We did it in that
No, we
apartment.
did it was with,
In
yeah,
the
the apartment with
The
Ms.
fire
Harmon,
apartment.
with Dr. Schreiber. And you had the little, the bags in your shoes.
Oh, yeah, that's right, y'all did do it first
They
semester.
fed us for empathy though, that was what
Right,
it was for.
okay. We did it a little bit different in the second semester over in the sim lab with days. So we didn't feed each other, but very similar. We had the same goal for like us to understand some different things with our vision and things like that. So tap back into some of those concepts that you were thinking of and like kind of what you experienced with the goggles on and that sort of thing. I think one of the big things that I've seen come up time and time again is your difference between your cataracts and your glaucoma, okay? So with cataracts, we know that it's a clouding of the lens, right? Which can lead, I mean, that can just cause a little bit of impairment all the way to being totally blind in that eye. Now cataracts, what can we do?
You can do cataract.
We can do cataract surgery and cut it out and remove it, right? Which restores some of that sight. My dad actually just had cataract surgery this year on both of his eyes, and he was like, if I had known I could see like this, I would have done it 20 years ago. You know, he was like, I didn't realize how bad my eyesight was until they did it and they cleared the cataracts. So there are different things that we can do. Obviously surgery is one. If you could imagine having to look through this, wouldn't be very easy, right? And then when you compare that to glaucoma, what do we know that glaucoma is?
Increased eye pressure.
Yes. It increases the pressure on the optic nerve, and it causes damage, which results in the vision loss, okay? What's something that everybody knows is used sometimes to treat glaucoma? Marijuana, yeah, because it helps relieve some of that pressure on the optic nerve, and then that way some of that pressure is off and it helps not progress the glaucoma, okay? With glaucoma, they do have that increased intraocular pressure because they're not able to drain that aqueous humor that is held in our eye, which is what causes that increase of the pressure on the eye and the optic nerve and damages it. I'm just trying to comb through here and see what all I want to double touch on. Glaucoma, a good thing to know down there in the notes is glaucoma is a leading cause of irreversible blindness across the world. So remember, for our cataracts, we could do something about it, right? Like if it was severe, we can remove the cataract with glaucoma, we can't necessarily remove glaucoma. The damage has been done to that optic nerve at some point. They do have a couple of different types of glaucoma. You have primary open angle glaucoma, or POAG. That's the most common one. And then we also have angle closure glaucoma, which is less common, and that usually is due to just like a sudden blockage of the drainage of the aqueous humor. But your primary open angle is your more common one. Peripheral vision loss is your hallmark of your glaucoma, whereas your cataract is usually more centralized because it's covering that lens. Oftentimes with your primary open angle glaucoma, they're initially asymptomatic. I think the term that they use is like the silent thief of sight or something like that, because they can be asymptomatic until all of a sudden they just like are losing their vision rapidly, because they don't have noticeable symptoms up until that point when they really start to notice that they're losing that peripheral vision, and it continues to escalate. Since they are having that peripheral vision loss, sometimes they may describe like tunnel vision with glaucoma, okay? So if someone ever starts describing that, maybe it's worth us looking into, right? And we remember that testing for peripheral vision, like you're not necessarily just it's not like our stroke assessment where we're just going like this for them, right? Like you gotta actually get like over behind them and say, hey, can you see how many fingers I'm holding up on this side, and that sort of thing, okay? Most of the time, most every issue other than just like nearsightedness and farsightedness is obviously corrected with corrective lenses or LASIK surgery if it's severe enough, or contacts, or include some type of eye drops. And a lot of times they'll include a combination. If you've done eye drops in the hospital, you realize that it's rare that you only ever put like one eye drop in somebody's eyes, right? A lot of times they may do like a beta blocker eye drop, which what do we know that the beta blocker does?
Lowers the heart rate and lowers blood pressure.
What do you think it might do to the eye?
Low pressure.
Could lower the pressure, but what's it also do? What's it doing systemically in the vessels? It opens it up, right? So a lot of times they'll do the beta blocker drops first, and then it opens up, so then you absorb your second drop a little bit better. Usually they want you to wait like 2 to 5 minutes in between different types of eye drops, because if you just like throw one in there and then throw the next one in there, it's probably not doing what they intended for it to do. But sometimes patients forget that. Sometimes we get in a rush and we don't pay attention to that, or we don't think to do it. But good to make sure that you're aware of if you do have to do multiple different ones. Macular degeneration. Anybody heard of that? Okay. What's the macula in the eye? Anybody remember? It's the central part of your retina. Okay, so what's happening with macular degeneration is that starts to deteriorate. And when that starts to deteriorate, you have like central vision loss. And so since it's which makes sense, right? If it's the central part of the retina and we start to deteriorate there, we're gonna have central vision loss. So remember our glaucoma, we started losing peripheral first, and then here we're gonna start losing central vision loss. One of the things that we did in our center thing to create macular degeneration was we put like stickers in the middle, so you had to kind of look around, and it kind of gave the idea of what those patients may experience. I have under all of these, like the tests that they undergo, it's a lot of really fancy words, but most of the time they're doing like pressure studies to see how much aqueous humor is in there. They're doing normal vision tests. They're putting dye in to see if there's abrasions. It'll highlight different parts of the eye to see if there's like cataracts or glaucoma or whatever it may be. In my experience, it's not typically asked of y'all to really know the ins and outs of the diagnostic. Now, to have an idea of some things that they may undergo, sure. but to know like, oh, specifically for this, they're gonna have this fancy test that is only done in the ophthalmologist's office, that sort of thing. Not my experience that y'all are required to really know all the ins and outs of that, okay?
I know that's drusen.
Do I?
Drusen, the yellow,
Oh,
that's what I have.
oh, okay,
Dry, drusen,
okay. That's-
versus wet, drusen.
Gotcha.
Dr. Chuck?
I'm gonna be real honest, I didn't know what you were talking about. Nice. Alright, detached retina. So this is a big one that they could easily ask some questions about. Do we want our retina to detach from where it's supposed to be?
No, because fine.
Right. So the retina is a thin layer of tissue at the back of the eye, okay? When that separates from the supportive tissue underneath it, that's a detached retina. This is a medical emergency, okay? It needs to be treated immediately to be able to restore the sight, and we don't want there to be any further damage after that. A lot of times that involves them having to lay prone for an extended period of time. Because we don't need it to be up and changing the pressure and that sort of thing and have any room where it could be able to move around. A lot of times they will describe seeing like floaters in their vision, flashes, and then they have the like hallmark thing that I've seen mentioned is the curtain-like shadow. So it's like someone's kind of closing the curtains in, and that I know for sure I have seen on like HESI prep questions, NCLEX, things like that, because they want you to know about that. It's kind of like your DIG toxicity, you know, they want you to know about the yellow rings, that sort of thing. That curtain-like shadow is what's done with, or is what's correlated with detached retina. Diabetic retinopathy. So if we had to guess, who's probably experiencing this? Okay, is it gonna happen suddenly or over time? Over time, it's progressive, okay? It just causes damage to the blood vessels that feed to the retina because of long-term diabetes and unmanaged diabetes, or poorly managed diabetes, I should say. And this is the leading cause of blindness in working age adults. Hypertension also contributes, as well as hyperlipidemia. They can have little microaneurysms, which is just leakage of blood and fluid that are right there in that vasculature to the eye. They have multiple different stages. The one thing with the diabetic retinopathy is the vision can kind of fluctuate. So you'll have patients that describe that blurring vision, but maybe it's not always the same amount of blur. Like it'll kind of fluctuate depending on the actual vasculature and how much blood flow is getting there at that time. The real important thing here is to talk to them about controlling their blood sugar so it doesn't continue to get worse. Okay. For all of these, especially that are causing vision loss or changes, significant changes in their vision, emotional support is a big one, right? Because that's a big change in their life. Especially with some of these that can happen so suddenly, right? Eye injuries. Ironically, one of my brothers actually called me yesterday because he has a corneal ulcer and it sounded absolutely miserable. So, don't recommend. But we do know that we can burn our eye if we get things in our eyes. You know, there's always all those warnings about like cleaning materials and things like that. Like, oh, don't get in contact with the eye. They really do mean it. It's not just because it'll irritate it. It's because it can cause an actual chemical burn to the eye and lead to blindness. So it's not just because you don't want it in your eye. Foreign bodies, obviously that's obvious, right? Like if something gets stuck in there. If you were to have a patient that did have something stuck in their eye, are you gonna get it out?
No.
No. You would most likely try and put something around, especially if it's like really protruding, put something around that would try and hold it still, right? Block a little bit of the light, cause they're gonna probably be pretty sensitive to the light. That way they're not like looking around because they're frantic and it's like flapping around everywhere. And then let someone that gets paid a lot more than us take it out. So, it can be anything from tiny little like dust particles to metal, wood, sawdust, all of those different things. And they can become embedded. Sometimes they, like if it's really small, sometimes it just kind of has to work its way out. Sometimes they'll flush it out really well. And other times they have to actually surgically go in and get whatever it is out so it doesn't cause further damage. Sometimes if it does scratch across the cornea, then that could potentially create scarring. I have a scratch that goes across my left one from getting hit in the face with a stick when I was little. And so like I always have like a tiny little blurred line. I don't even really notice it anymore, but I can focus on it if I think about it, because it caused a little scarring from where I had my cornea scratched. What else? Corneal ulcers, they can actually spread. So whatever's in there that's kind of the irritant that's causing it, if they're not able to locate it or not able to get it washed out, that can cause that corneal ulcer to continue to spread further on the cornea. They do numbing drops to try and relieve some of the pain because it is extremely painful. And then they'll do some other like medication, like a lot of times, I think for my brother yesterday, she prescribed him like an antibiotic to make sure that he didn't get an infection in case there was like, anything else got into the eye, to the ulcer. And I think she did a steroid too, to try and help with some of the inflammation on top of the numbing. And then the hope is that it gets treated and it doesn't cause the scarring, but unfortunately, sometimes it does, and the size of the ulcer is obviously gonna depend on how severe that scarring is and how much it might interfere with your vision. Very sensitive to light with most of those. Y'all remember learning about the visual acuity test? Y'all remember what like 20/20 means, right? And like 20/10? Okay. This one goes through like, if I mentioned any of these different type of tests, there's a definition and like explanation of what each of those are under the notes portion. I won't bore you with the details of all of those. Like I said, they have so many, it's honestly amazing how many tests and different exams they have for eyes, considering they're very small. But they are very important, so I get it. The next couple, I think the next slide just really talks about what are you gonna do as the nurse to kind of help them. We already talked about most of this. Safety is a really big one. Any questions about eyes? And again, since I wasn't even thinking when I was saying create some questions today that y'all had y'all's test yesterday, when y'all start looking at this, if you come up with some and you've like worked it out, just email me. I mean, I know I'm part-time, but I do look at my emails. And if you have a question, I promise I'll answer it to the best of my ability, okay? So if you think of some as you're going, just shoot me an email and we'll get it figured out, okay? Switching gears over to ears, we have our hearing loss. So conductive hearing loss is usually when there's like an obstruction or damage to the outer or middle ear that makes it to where the sound that you're hearing is not transmitted as easily to the inner ear. So think of like if you get something stuck in there, if you, like I've had patients that have a little bit of hearing loss because they had like a bug bite or something like in their ear right there and it swelled up really big, and so there just wasn't enough movement of that sound coming in. And then you've also got your ear infections that can cause some of that because you hold that fluid in so it can't get down to your inner ear as easily. If you perforate your eardrum, that's another one. Then we switch over to our sensoroneural hearing loss. It's getting close to my bedtime, I can't talk. So this is just like a dysfunction of the actual inner ear and the auditory nerve that is able to interpret that. This is usually more of what we're talking about when we're thinking about like age loss or age hearing loss, right? Or hearing loss that's more of like a chronic thing that's happening, not an acute issue. And then you have mixed hearing loss, which is just a combination of both, right? That's what mixed means, okay? And that's usually the mixed portion of it also being because it affects both the middle and the inner ear. It's not just one or the other. With your sensorineural, that's a difficult word. That one you can attribute some to like prolonged noise exposure. So if you're talking about somebody that goes to like rock concerts every weekend and that sort of thing for years, that repeated exposure could do with it. Someone that works in a factory that's not wearing hearing protection, things like that. Military, you see it a lot because of like if they're not wearing earplugs or headphones or anything and they have a lot of loud noise over an extended period of time, or even one significant event of really loud noise that damages their inner ear. So that's kind of more of what you're thinking of with your sensorineural. Some other things, obviously we talked about the aging, the noise exposure, ototoxic medications. What's like the number one ototoxic medication that y'all know about? What? Well, yeah, we did talk about that one. What's the other one? If you don't give it correctly. Furosemide. Yeah. You push IV Lasix too fast, you're gonna kill their hearing, they're not gonna get it back. If you have to push Lasix at the actual push rate. I mean, you have to do it with all of them, but I've seen it happen where someone pushed it too fast and then lost they had ototoxicity. And it doesn't come back when the Lasix wears off. You have created the damage is done. So when we tell you push rates, we actually mean it, okay? But that's one that is very easily linked with your ototoxicity is furosemide. Vanc is definitely one. And so when you see some, like when you're looking at more and more medications and you see that ototoxicity, it's just important to just note it. Genetics, some hearing loss is genetic, not all. Oftentimes when hearing loss starts, what is kind of one of the first symptoms that you may notice? Or maybe that you notice that somebody else, like if somebody else is developing hearing loss. Maybe, or maybe they just don't understand what you're saying, like they can't make out the words, like you're gonna have to enunciate more, right? It's not necessarily the volume, but it's like you sound a little bit more muffled than you really are, okay? Obviously one of the first things that they're always gonna do is make sure you don't have anything stuck in there, right? Because if it's as easy as getting something out of your ear to fix it, then we like that. And then it can advance all the way to hearing aids to cochlear implants. Okay, we won't really get into like the diagnosis or the criteria to have a cochlear implant, but there are options for some people. There are also options for pediatrics for them to have an implanted cochlear implant.
Cochlear is the one that had like the magnet that's
Yeah, they do the implant in the brain that helps like transmit the noise. So essentially what it's doing is you have the hearing aid that's here, where you're getting the noise, it goes to that hearing aid and then it transmits through where it's connected in the magnet and it takes it to your brain to be like, oh, that's what they said.
I had that patient in the ICU.
That's why sometimes I just take them off if they don't wanna listen to me.
He was an older man and I walked in and started talking to him and he was just like staring at me and he's like, I got a hearing aid.
Yeah.
You put it in, I was
Yeah.
like, oh, okay.
Yeah.
Snap it on.
Now, regular hearing aids, you know, like they have ones that you can barely even see now. I mean, they're like itty bitty tiny that you don't even notice. They've made it a lot more accessible and a lot more, maybe not as socially anxiety inducing, especially to younger people that may suffer from hearing loss that require hearing aids. And so you have some that are basically not even noticeable, and then you also have ones that are over the ear, so they may have, like, they have some that fit over the ear and they have a little pack right here. Now that's still just a regular hearing aid, it's just they have an over ear component to kind of keep it where it is. It's kind of the difference in like AirPods and over the ear, you know? And then your cochlear implant has like a cord and it has a little circle that attaches back here with the magnet like he's talking about. And I have a friend that has bilateral cochlear implants, and he always cracks me up because when he's done listening to people, he just takes them off. And he just lives in his nice little world. He loves it. He's like, I just live in my nice little world of silence. I don't know no better. He's like, no, when I'm ready to listen to y'all again, I just pop them back on. So, but also with that, I think that with cochlear implants, well, I don't think I know, their perception of whatever noise that they're hearing is gonna vary. Like some people have fantastic hearing and they're able to really understand with the cochlear implant. Some people, they need to be like looking at you to kind of create the connection of seeing you talking with it transmitting correctly. Some people it's very quiet, a little bit muffled. They go through a lot of adjustments when they get their cochlear implants to make sure like the volume is correct, that there's not any ringing in their ears and things like that. It's not heavily talked about in the module, but tinnitus is one just to be aware of, like ringing in the ears. That can change, it can be very annoying for people to have a constant ringing in their ears, and it can change pitch. Sometimes that's due to the fluid and how they hold fluid. A lot of times we associate tubes with pediatrics, but adults can actually get tubes in their ears too to help drain some of that fluid to help with some hearing loss and some tinnitus and that sort of thing. So again, here, this is kind of highlights of what I would focus on, make sure that you're just remembering to walk through like your risks, your symptoms that they're gonna experience, what are we gonna do about it, and how am I gonna help this patient manage it, what's the education provided, and then also, how am I gonna work with a patient that has a sensory deficit, whichever one it may be. Go back to your 112 stuff, how do I put in eye drops? Do I touch it to their eyeball? No, you don't, right? Do you stick the tube down in their ear to put the drops in? No, you don't, right? What do you do with the ear? Do you pull it down and back or up and back? In an adult. Okay, what about in a kid? Okay, so review some of that so you're sure about those simple things, because don't let something like that be the thing that kicks you in the butt on a test, right? Because it's simple, it shouldn't be complicated. What other questions do y'all have? Any?
We'll email you.
What was your question? I wrote it down, but now I don't know which sheet of paper I wrote it down on earlier that I was gonna look up.
Oh, it's the answer on the
Oh, yes. Let's see. What is Google?
Chat GPT didn't, I think it does.
Yes, it can metastasis